We began this section with the 64-year-old male who was seen for physical therapy through an outpatient clinic following a cerebral vascular accident in the distribution of the left middle cerebral artery due to thrombosis with the resulting right hemiparesis. There was no other significant medical history. Upon admission for the physical therapy, the medications were known to be aspirin, warfarin, and Tylenol. Aspirin and warfarin both being blood thinners or hemolytics. Physical therapy, as we recall, found some mild receptive communication deficits and requested physician referral to the speech-language pathologist. Nursing had also reported deficits with the performance of the activities of daily living and requested physician referral for occupational therapy evaluation. The speech-language pathologist noted in the first few days of therapy the patient would be participating in therapy and then fall asleep in the middle of saying a sentence. The speech-language pathologist further noted that when the patient awoke a few minutes later that he would pick up and finish his sentence where he had left off. Both the speech pathologist and nursing staff reported excellent progress in the first few days of therapy. However, the follow-up instrumental assessment was requested 2 weeks early due to the staff report that the patient now presented with tardive dyskinesia, lingual fasciculations, increased confusion, and severely decreased swallow function. The patient's medications were Novolog insulin, simvastatin, low pressor, digoxin, and scopolamine. So let's list them out. So by diagnosis, our patient is taking aspirin and warfarin as hemolytics for their stroke. They're taking Novolog as insulin for the type 2 diabetes mellitus. They're taking the statin medication of simvastatin for both the peripheral vascular disease as well as the coronary artery disease. This patient's taking low pressor for their high blood pressure or hypertension, and digoxin for the atrial fibrillation, as it was suspected that the atrial fibrillation was causal in throwing the clot that caused the initial stroke. Lastly, the patient is taking scopolamine due to reports of hypersalivation and congestion. Now, when we had the request to go back and follow up a couple weeks earlier than what was planned on this patient, we started with the chart review. And we went back through the chart and we discovered that the scopolamine actually had been added when this patient had come back into this nursing home. And although there was a note saying it was for hypersalivation and congestion, there wasn't any clinical documentation reporting difficulty with hypersalivation or congestion prior to the scopolamine being added. So we went and asked the nurse, what prompted the physician to order the scopolamine? The nurse said, well, talk to the DON. So we went and talked to the DON. We asked the DON, what prompted the physician to order the scopolamine? And the DON said, well, this patient was here a year ago for something else, and she had lots of hypersalivation and congestion then, for which she took scopolamine back then a year ago. So we just thought that the physician should add it. Well, when we looked up the effects of the scopolamine, we found that some side effects included the tardive dyskinesia, the lingual fasciculations, confusion, and some impairment with swallow function. Therefore, we called the physician and thanked the physician for the early follow-up referral, and asked the physician if he wanted to go ahead and have that follow-up study conducted today, or would he like to evaluate his patient for discontinuing the scopolamine, wait a couple weeks, and have us come back in a couple weeks to reevaluate the patient at that time. The physician elected to discontinue the order for follow-up instrumental assessment and elected to have us come back 2 weeks later after being taken off the scopolamine, and the patient had made tremendous progress at that time with the therapy and was advanced back to thin consistency liquids and regular consistency foods. So This is another example of the importance of therapists of all disciplines, not just speech pathology, looking at the medications and considering what is going on. As the physician and the rest of the team were trying to figure out this brain stomper, if you will, everything appeared to be stable with his blood work and urinalysis, etc. Each diagnosis appeared to be receiving appropriate intervention at that time. So later, the attending physician went on his lunch break and met with his wife, who happened to be a registered dietitian. He told the story to his wife, the registered dietitian, and she asked, after listening carefully, what did Mr. Banana Man actually eat during those football games? So the physician went back and asked the patient and his wife, who was present, and according to his wife, Mr. Banana Man was eating about 10 to 12 bananas over the course of the Sunday football game he was watching. So even though he was hypokalemic in terms of medical history, and he was taking his potassium chloride, plus he was getting a monstrous load of extra potassium from these 10 to 12 bananas that he would eat during his football games. And this was throwing him into transient hyperkalemia, which accounted for his difficulty. As we look at these two cases, in both cases the patients were admitted for an acute onset of altered mental status, disorientation, confusion, and generalized weakness. In both cases, there was no history of dementia and no focal neurological signs or symptoms characteristic of cerebral vascular accident or transient ischemic attack. With both cases, we did have a history of insulin-dependent diabetes mellitus. We also saw an elevated neutrophil count on the complete blood count, which indicated a systemic infection was in progress. Now, the metabolic acidosis was confirmed in the form of diabetic ketoacidosis. During the taking of the history, as the cases progressed, it was learned the patients had forgotten to take their insulin in both cases. Perhaps dealing with the fever and trying to get extra rest from being sick with a systemic infection and the fever and the sequela that followed may have contributed to both patients' oversight in taking their insulin. This was particularly dangerous because we know with diabetics that when there is an infection in place, they may have a need for increased insulin. Regardless, in these two cases, the failure to take their insulin resulted in a shift to metabolization of fatty acids since glucose uptake was impaired secondary to inadequate insulin. The large amount of ketones had overwhelmed the buffering system, and acidosis resulted as evidenced by a significantly low pH measurement of both patients' blood. The resulting hyperkaluria, which resulted in concurrent hypokalemia and the resultant loss of extracellular sodium, which caused a concurrent hyponatremia, which, as we recall, is going to cause the brain to swell, were also evidenced in the blood work of both patients. The combination of these electrolyte imbalances, along with the starvation of the brain due to the impaired glucose uptake, collectively resulted in the severe cognitive deficits, severe ADL deficits, severe cognitive communication deficits, and the appearance of the moderate oropharyngeal dysphagia. So, what was the difference in these two patients, other than one's male, one's female, and they were 9 years apart?